Hello everyone. We continue our discussion about iron deficiency anemia. This is the part 2 of iron deficiency anemia. The part 1 I have taken in anemia part 4A. Okay, this is the today's is part 4B, and I'm sure you have seen the 4A. If not, I'll strongly suggest you to first see that anemia IDA part 1, which is there in anemia part 4A. In the previous section, I covered about pathophysiology of iron, the clinical feature of iron deficiency anemia. Now I'll be talking to you regarding investigation and treatment. Well, when we talk about investigation, for every anemia, one of the best initial tests is peripheral blood film. So we make a peripheral blood film here also. This is a normal peripheral blood film. You can see RBC with some central pallor is there. Yeah, this is there. So now in anemia, iron deficiency anemia, this central pallor is increased and the RBC size is even becomes smaller. So in peripheral blood film, you get microcytic hypochromic anemia. In fact, little bit basic concept, normal RBC size is 80 to 100 FL. FL. If the size is less than 80, you call as microcytic anemia. The size of RBC is between 80 to 100, we call as normocytic anemia. Normocytic. And if it is more than 100, we call as macrocytic anemia. So in this case, it is microcytic. Hypochromic, this is the RBC's central pallor is there, and this all is the pink area. So now, what in iron deficiency anemia, the size becomes smaller, but central pallor increases. So size becomes smaller is microcytic, central pallor increases, that is hypochromic anemia. So now you are convinced that in case of we are getting microcytic hypochromic type of picture, you can see central pallor are enlarged to a great extent. After that, we talk about red cell distribution width, what we call as RDW. Let's learn the basic concept. RDW is essentially indication of degree of anisocytosis. Anisocytosis means variation in size of RBCs. Normal reference range is 11.5 to 14.5, but you will never understand unless I show you this picture. Look into this. Here we got so many RBCs, by and large they are in the same size. Now look into this. This very big RBC, small RBC, small. So we are getting various sizes we are getting. So this is known as anisocytosis, is the variation in size. And that is the parameter we determined by RDW. So you can see in RDW is increase in iron deficiency anemia. Serum ferritin is the best parameter to know about iron deficiency anemia. In the previous section, we have seen the ferritin was a storage form of iron, maybe in the enterocyte or maybe in the bone marrow spleen also. Reduced serum ferritin is one of the earliest manifestation of iron deficiency anemia. Rather, you can say otherwise, if lab parameter we have to indicate less than 15 microgram per liter is diagnostic of iron deficiency anemia. Well, ferritin is an iron storage protein in liver and macrophages. Okay, the point I discussed in the previous section in part 1 of IDA lecture. Now, one thing is very clear to you, that it is a ferritin which is going to generate iron, which will be being used for hemoglobin formation, and that will be ultimately RBC count will be there. So when iron deficiency anemia is there, initially ferritin level will go down. It will try to maintain, initially ferritin level go down, but that will try to maintain normal serum iron. Hemoglobin will be normal. So once the ferritin level has gone to critically low level of 0.15, then free iron and HB level will go down. That means fall of free serum iron in the blood or HB level will occur much late. That's why I told you is the best parameter, the earliest parameter to is to get the range is reduction in serum ferritin level. Well, let's talk about serum iron and iron binding protein. This is again a very confusing point. Let us learn the basic concept. Well, this is the total iron binding capacity. And maybe this part, the iron is serum iron is attached. So this is a saturated part, and this is the part where unsaturated iron binding capacity, here more and more iron can bind. Let me give you an example. This is the total iron binding capacity. And now this is iron is this much is bound to iron. So now what we are getting? We are getting this much place. We are getting a huge place where iron can still bind. So now the iron binding capacity is increased iron binding capacity. Well, we get more iron. We get more iron. Now the iron is like this. Now the iron binding capacity is how much? This. Now the iron binding capacity is reduced. As the iron level will go increase, the iron binding capacity will be reduced. Okay. So in iron deficiency anemia, iron binding capacity is increased. Serum iron is reduced. Serum iron is reduced and iron binding capacity is increased in iron deficiency anemia. So same thing here also. Again, serum iron level represent the amount of circulating iron bound to transferrin. Total iron binding capacity and indirect measurement of circulating transferrin. Normal range of serum iron is 50 to 150 microgram per 100 ml. And normal range of TIBC 300 to 360 microgram per 100 ml. With this basic background, now let's talk about very confusing transferrin saturation. Transferrin saturation is serum iron, total iron binding capacity multiplied by 100. I told you in iron deficiency anemia, serum iron is reduced and total iron binding capacity is increased. So definitely in transferrin saturation will be reduced. Transferrin saturation will be reduced in iron deficiency anemia. Simple mathematics. Simple mathematics, if you look into this, 300 to 360, let's say 300, 50 to 150. So let's say patient has iron deficiency anemia, 50 serum iron and 300 is TIBC. And we have got one condition where serum iron is normal and 3. This is 0.5 and this is how much? Almost 15%, I suppose. You multiply 0.15. Okay. If you multiply by 100, it comes to be 50% and this comes to be around 15%. So now you understood the meaning of serum iron divided by TIBC multiplied by 100 is as transferrin saturation. It will be reduced in iron deficiency anemia. It will increase in iron overload state. So normal transferrin saturation is 25 to 50%. In IDA TAS level below 20% and over 50% indicate iron overload state. It is a summary of what I discussed in the previous slide. Serum ferritin level is inversely proportional to TIBC. Now, by now your concepts are clear, I suppose. Red cell protoporphyrin level is increased in iron deficiency anemia. For that, we got to know the basic concept. Let's learn the basic concept. This is the developing RBCs. And in a normal condition, protoporphyrin is made, and this combined with iron, and they make heme. They make heme. This normal. Heme is getting made by combination of protoporphyrin with ferrous. Suppose there is iron deficiency anemia. This is less. Plus protoporphyrin is made normally. So what happened? We will be getting RBCs where protoporphyrin are there to make heme, but there is no ferrous. No ferrous, but protoporphyrin, as I told you, are being made normal. So this free protoporphyrin level will be increased because there is no ferrous. Well, I can give you day-to-day example. This is the pen. This pen is there, a cap is there, and together they make a full pen is there, which you get from the market. Suppose there is a factory where these pens are getting made, and what happened in the factory? One machine is making this cap, the other machine is making this pen. Suppose the machine which is making this pen is not working, there is some technical problem, but the machine which is making cap is making normal caps, but there are no actual pens. So now the factory will have only caps, no pens. So this pen will not be there. Exactly same thing. This is the protoporphyrin, and this is the pen. Pen is not there, but there are lots of free caps will be there. So in iron deficiency anemia, this free protoporphyrin will be there, and HB level will be reduced. Now let me add on to your knowledge. In sideroblastic anemia, reverse happen. Problem lies is in the excess of iron is there. Excess of iron is there, and that get deposited into the mitochondria. So we get a type of sideroblastic anemia, which is there around the in the circular form in the mitochondria. Well, I have taken a separate lecture for sideroblastic anemia. That detail you can see there. But as of now, we come back. We understood in iron deficiency anemia why free protoporphyrin level will be increased. Well, transferrin receptor proteins we discuss in the part 1. A quick recap. What I told you, that transferrin, T for transferrin, and this is the membrane of the bone marrow cell, and here we have a transferrin receptor. This transferrin will go and get attached to transferrin receptor. Okay, so this complex is made, and this complex is taken inside the cell via endocytosis, T plus TR. They enter the cell, and ultimately by endocytosis, T plus TR, they enter the cell where this iron will be consumed. So we have a transferrin receptor in the membrane of the cell of the bone marrow. In iron deficiency anemia, the receptor number will increase, so that they want whatever iron is coming via transferrin, they want to take it inside. So in iron deficiency anemia, the level of this receptor, TRP receptor, increases. Okay. So these levels are elevated in iron deficiency anemia. So the pathogenesis of the iron deficiency anemia, basic concept: mobilization of the iron from the storage site, maybe bone marrow, maybe macrophages. This is bone marrow, maybe macrophages. So serum ferritin get reduced. The first thing to happen in iron deficiency anemia, initially serum iron, TIBC, RBC, they all are normal. And later, so by definition we say the patient has iron deficiency anemia when the serum ferritin store are less than 15 microgram per liter, that indicate that iron storage, that storage form of iron is reduced. As long as the serum iron remain normal, the hemoglobin synthesis is unaffected despite dwindling iron stores. When the transference saturation falls to 15 to 20%, hemoglobin synthesis become impaired, and that means the serum ferritin level has again gone down drastically. So now we get microcytic anemia, and now hematocrit tend to fall. So finally we learned that we got the all investigation done, how to manage. We have to replace by ferrous sulfate. Why ferrous sulfate? Because it is this form, iron get absorbed without any problem, and it will not be making any complex in the stomach with phytate sulfate. So that's why it's always given in ferrous form. It's normally we treat by oral iron preparation, usually treatment. Vitamin C is sometimes added to improve iron absorption. How do you know the patient is improving? You have to go for reticulocyte count to be done. When you will do 4 to 7 days after starting, because from pluripotent stem cell to retic count, it takes about 5 to 7 days or 4 to 7 days. And from retic to RBCs, it takes about 2 days. That means from pluripotent stem to RBC, somewhere around, total is around 9 days. So only after 9 to 10 days, the HB levels will start rising. Parenteral iron therapy is uncommonly used, but we have to give in situation where they're not able to tolerate oral iron, because that can lead to a lot of GI disturbance. Okay, intolerant to oral iron, or they are not able to absorb. So we can give intravenous route, sodium ferric gluconate or iron sucrose. IM route, iron dextran and iron sorbitol citrate. Now I have a question for you. Suppose you plan to give IM route, it has to be always deep intramuscular. Now what is the technique they use to give intramuscular injection? Stop the video, write down the answer. The answer is, it is given by Z technique. Well, this is the skin, this is the muscle and skin, muscle. You put the needle comes in, this needle has come in. Use about 1 ml, you push. After that, you pull the skin to one side. Okay, so now push more. That means the initial part went at this place, and now as you have pulled the skin to other side, next part will go to this place. So ultimately it will be something like Z technique, what they call as. We don't inject a whole drug at one place. We inject the drug in different, with the same syringe, same needle inside. Just by pulling the skin to one side, we keep on injecting the drug in the parts. This is so-called Z technique. Last minute revision point, investigation, we get microcytic hypochromic anemia, increase RDW, serum ferritin reduced, best parameter to know about iron deficiency anemia. Transference saturation is serum iron divided by TIBC multiplied by 100. Lab value which indicate iron deficiency anemia, very important slide, decrease ferritin, HB, MCV, transference saturation. Even MCH is also reduced. Increased TIBC, RDW and serum transferrin receptor proteins, they are increased. Treatment oral replaced by ferrous sulfate, never by ferric. Parenteral route, IV route, sodium ferric gluconate, iron sucrose. IM route, iron dextran, iron sorbitol citrate, and given by Z technique. Thank you very much.